We are going to discuss structural heart disorders. This information can be found in Chapter 36 in your Lewis textbook. Objectives for this lecture include discussing the causes, pathology, and manifestations of structural heart disease. We will also look at comprehensive planning for these patients. The heart contains two AV valves, your mitral and tricuspid, and two semilunar valves, your aortic and your pulmonic, which control blood flow through the heart. Your heart valves are specialized flap-like structures that allow blood to flow in one direction through the chambers. Valvular heart disease is characterized according to the valve or valves affected and the type of dysfunction, such as stenosis or regurgitation. The pressure on either side of an open valve is normally equal. However, in a stenotic valve, the valve opening is smaller. The forward flow of blood is impaired. This creates a difference in pressure on the two sides of the valve. The amount of stenosis is seen in the pressure differences. When regurgitation occurs, closure of the valve is incomplete. This results in the backward flow of blood. Most cases of adult mitral valve stenosis result from rheumatic heart disease. Rheumatic mitral stenosis is widespread in underdeveloped countries. Less common causes are congenital mitral stenosis, rheumatoid arthritis, and systemic lupus. Rheumatic endocarditis causes scarring of the valve leaflets and the chordae tendae. These deformities block the blood flow and create a pressure difference between the left atrium and the left ventricle during diastole. As a result, left atrial pressure and volume increase, causing higher pulmonary pressures. The overloaded left atrium places the patient at risk for the development of atrial fibrillation. The stenosed valve is unable to open sufficiently during left atrial systole, inhibiting left ventricular filling. The stenotic mitral valve takes on a fish mouth shape because of the thickening and shortening of the mitral valve structures. The primary symptom of mitral stenosis is exertional dyspnea due to the reduced lung compliance. Heart sounds include a loud first heart sound and a low-pitched diastolic murmur, best heard at the apex with a stethoscope. Fatigue and palpitations from atrial fibrillation may also occur. Emboli can arise from the blood stasis in the left atrium secondary to this atrial fibrillation. Less often, patients may have hoarseness from atrial enlargement pressing on the laryngeal nerve, hemoptysis from pulmonary hypertension, and chest pain from decreased cardiac output and decreased coronary perfusion. Mitral valve function depends on intact mitral leaflets, a mitral annulus, chordae tendineae, papillary muscles, left atrium, and left ventricle. A defect in any of these structures can result in regurgitation. Damage to valve caused by myocardial infarction, chronic rheumatic heart disease, mitral valve prolapse, muscle dysfunction, and infectious endocarditis. A myocardial infarction with left ventricular failure increases the risk for rupture of the chordae and acute MR. MR allows blood to flow backward from the left ventricle to the left atrium due to incomplete valve closure during systole. Both the left ventricle and left atrium must work harder to preserve an adequate cardiac output. In acute MR, the sudden increase in pressure and volume transmits to the pulmonary bed. This results in pulmonary edema, and if not treated, cardiogenic shock. In chronic MR, the additional volume results in left atrial enlargement, left ventricular dilation and hypertrophy, and finally a decrease in cardiac output. The clinical course of MR is determined by the nature of its onset. Patients with acute MR often will have a thready peripheral pulse and cool, clammy extremities. A low cardiac output may mask a new systolic murmur. Rapid assessments such as heart cath and intervention, such as a valve repair or replacement, are critical. Patients with chronic MR may remain asymptomatic for years. Early symptoms of left ventricular failure may include weakness, fatigue, palpitations, and dyspnea. These gradually progress to orthopnea, paroxysmal nocturnal dyspnea, and peripheral edema. Increased left ventricular volume leads to an audible third heart sound, S3, even with normal left ventricular function. The murmur is a loud holosystolic murmur at the apex, radiating to the left axilla. Patients with asymptomatic MR must be monitored carefully. Surgery, such as valve repair or replacement, should be considered before significant left ventricular failure or pulmonary hypertension develops. Mitral valve prolapse is an abnormality of the mitral valve leaflets and the papillary muscles or chordae that allow the leaflets to prolapse or buckle back into the left atrium during systole. It is the most common form of valvular heart disease in the United States. The use of the term prolapse can be misleading because it is used even when the valve is working normally. Mitral valve prolapse is usually benign, but serious complications can occur, including MR, infectious endocarditis, sudden cardiac death, heart failure, and cerebral ischemia. These figures show the mitral valve prolapsing or buckling when closed, and it kind of looks like a hood. Dysrhythmias, most commonly ventricular premature contractions, may cause palpitations, lightheadedness, and dizziness in people with MR. Infectious endocarditis may occur in patients with MR associated with mitral valve prolapse. Patients may or may not have chest pain. The cause of the chest pain is not known. It may be the result of abnormal tension on the papillary muscles. If chest pain occurs, episodes tend to occur in clusters, especially during periods of emotional stress. Dyspnea, palpitations, and syncope may occasionally accompany the chest pain and do not respond to anti-anginal treatments such as nitrates. Beta blockers may be given to control palpitations and chest pain. Encourage the patient to stay hydrated, exercise regularly, and avoid irritants such as caffeine. Patients with mitral valve prolapse generally have a benign, manageable course unless problems related to mitral valve regurgitation occurs. No accepted medical therapy appears to delay the need for valve surgery in this group. Although the etiology of mitral valve prolapse is unknown, there is an increased familial incidence in some patients. When teaching the patient or caregiver how to manage mitral valve prolapse, you should teach patients the importance of antibiotic prophylaxis for endocarditis before undergoing certain procedures. You should instruct a patient to take their prescribed drugs, such as their beta blockers, to control palpitations and chest pain. Advise patients to adopt healthy eating patterns and to avoid caffeines because as a stimulant it may exacerbate their symptoms. You should counsel patients who use diet pills or over-the-counter drugs to check for common ingredients that may have stimulants in them and exacerbate their symptoms. You should encourage the patient to begin or maintain an exercise program to achieve optimal health and wellness. Instruct patients to contact their healthcare provider or EMS if symptoms persist or worsen, such as palpitations, fatigue, shortness of breath, or anxiety. Congenital aortic stenosis is generally found in childhood, adolescence, or younger adults. In older adults, aortic stenosis is a result of rheumatic fever or degeneration. AS due to rheumatic heart disease accompanies mitral valve disease as well. Isolated AS is usually non-rheumatic in origin. The incidence of rheumatic aortic valve disease has been decreasing, but degenerative stenosis is increasing as the population ages. Aortic stenosis causes obstruction of blood flow from the left ventricle to the aorta during systole. The effect is left ventricular hypertrophy and increased myocardial oxygen consumption because of an increased myocardial mass. As the disease progresses and compensatory mechanisms fail, reduced cardiac output leads to decreased tissue perfusion, pulmonary hypertension, and heart failure. If left untreated, severe AS has approximately a 50% mortality rate in 1 year. Manifestations of AS develop when the valve orifice becomes about 1/3 its normal size. These manifestations include the classic triad of angina, syncope, and exertional dyspnea, reflecting left ventricular failure. Auscultation of AS often reveals a normal or soft S1, a diminished or absent S2, a systolic murmur, and a prominent S4. Aortic regurgitation may be the result of primary disease of the aortic valve leaflets, the aortic root, or both. Trauma, infectious endocarditis, or aortic dissection can cause acute AR and constitutes a life-threatening emergency. Chronic AR is generally the result of rheumatic heart disease, a congenital aortic valve, syphilis, or chronic rheumatic conditions such as ankylosing spondylitis or reactive arthritis. AR causes retrograde blood flow from the ascending aorta into the left ventricle during diastole. This results in volume overload. The left ventricle initially compensates for chronic AR by dilation and hypertrophy. Myocardial contractility eventually declines, and blood volume in the left atrium and pulmonary bed increases. This leads to pulmonary hypertension and right ventricular failure. Patients with acute AR have sudden signs of cardiovascular collapse. The patient develops severe dyspnea, chest pain, and hypotension, indicating left ventricular failure and cardiogenic shock, a life-threatening emergency. The patient with chronic AR generally remains asymptomatic for years. Exertional dyspnea, orthopnea, and paroxysmal nocturnal dyspnea develop only after considerable heart dysfunction has occurred. Angina occurs less frequently than aortic stenosis. Patients with chronic severe AR develop a water hammer pulse, a strong quick beat that collapses immediately. Heart sounds may include a soft or absent S1, the presence of S3 or S4, and a soft, high-pitched diastolic murmur. Diagnosis of valvular heart disease includes information from the patient's history and physical exam and a variety of tests. A CAT scan of the chest with contrast is the gold standard for evaluating aortic disorders. An echocardiogram reveals valve structure, function, and heart chamber size. A transesophageal echocardiogram and Doppler help diagnose and monitor valvular disease progression. Chest X-ray reveals the heart size, altered pulmonary circulation, and valve calcification. An EKG or ECG identifies heart rate, rhythm, and any ischemia or ventricular hypertrophy. Heart cath detects pressure changes in the heart chambers, records pressure differences across the valves, and measures the size of valve openings. An important aspect of conservative management of valvular heart disease is prevention and recurrence of rheumatic fever and infectious endocarditis. Treatment depends on the valve involved and disease severity. It focuses on preventing exacerbations of heart failure, acute pulmonary edema, thromboembolism, and recurrent endocarditis. Heart failure is treated with vasodilators, positive inotropes, beta blockers, diuretics, and a low-sodium diet. Anticoagulant therapy prevents and treats systemic or pulmonary emboli. It is used prophylactically in patients with atrial fibrillation. Atrial dysrhythmias are common and treated with calcium channel blockers, beta blockers, antidysrhythmic drugs such as amiodarone, or electrical cardioversion. An alternative treatment for some patients with valvular heart disease is percutaneous transluminal balloon valvuloplasty. During balloon valvuloplasty, the fuse commissures are split open. Balloon valvuloplasty is used for mitral, tricuspid, and pulmonic stenosis, and less often for aortic stenosis. The procedure is done in the heart catheterization laboratory. It involves threading a balloon-tipped catheter from the femoral artery vein to the stenotic valve. The balloon is inflated in an attempt to separate the valve leaflets. A single or double balloon technique may be used for the valvuloplasty procedure. Currently, the use of a single balloon with hourglass shape allows sequential inflation. This technique is the most popular because it is easy and has good results with few complications, for example, left ventricular perforation. The balloon valvuloplasty procedure is generally indicated for older adults and for those who are poor surgical candidates. The long-term results of valvuloplasty are similar to surgical commissurotomy. For patients with mitral or tricuspid regurgitation, further valve repair or reconstruction using annuloplasty is an option. Annuloplasty involves reconstruction of the annulus with or without the aid of prosthetic rings. The decision for surgical interventions, such as a valve replacement, depends on the patient's clinical state using the New York Heart Association classification system for functional disability. The type of surgery can be a valve repair or replacement. The procedure that it uses depends on the valves involved, the pathology and severity of the disease, and the patient's clinical condition. Valve repair is usually the surgical procedure of choice. It has a lower operative mortality rate than the valve replacement and is often used in mitral or tricuspid valvular heart disease. Although valve repair avoids the risk of replacement, it may not restore total valve function. Biological valves, or biologic valves, are constructed from bovine, porcine, and human cadaver heart tissue and usually contain some man-made materials. A decellularizing process removes the cadaver cells from the valve. This lowers the risk of immune response and tissue rejection. Biologic valves are asymmetric in shape and produce a more natural pattern of blood flow compared to mechanical valves. Asymmetric mechanical valve prototypes are being tested. Biologic valves do not require anticoagulation therapy because of their low thrombogenicity. However, sometimes they do require anticoagulants for very short-term basis, maybe a few months. Biologic valve replacements are less durable and tend to cause early calcification, tissue generation, and stiffening of the leaflets. Mechanical valves are manufactured from artificial materials and consist of combination of metal alloys, pyrolytic carbon, and dacron. Mechanical prosthetic valves are more durable and last longer than biologic valves. However, they have an increased risk of thromboembolism and require lifelong anticoagulation therapy. The main risk of mechanical valves is bleeding from the use of anticoagulants. The choice of valves depends on many factors. For example, if a patient cannot take an anticoagulant, such as a woman of childbearing age, a biologic valve is considered. A mechanical valve may be best for a younger patient because it is more durable. For patients over the age of 65, durability is less important than the risk of bleeding from anticoagulants, so most receive a biologic valve. So other more common procedures that are being done to replace aortic valves, more minimally invasive, are the TAVRs and the TAVIs. And the TAVR is very similar to a cardiac catheterization approach. They will take a guide wire with a stent that actually has a aortic valve inside of it or wrapped around the outside of it, and they will thread it up through the femoral artery, through the aorta, and up and through to where the original aorta is, or the original aortic valve is, and they will actually stent the new valve right over top of the older one. So this, again, is a more minimally invasive procedure. They're not doing a whole lot of these patients per year, but it's just another alternative to an open sternotomy and a more traditional approach. Some of the patients that are candidates for the surgery have a lot of comorbidities. They may be older and they may not be a candidate or tolerate a traditional procedure or traditional surgery. So by using these TAVR and these TAVI approaches, it minimizes recovery time, length of stay, and then it also reduces complications. So here's just another example of the stent graft, or the stent valve, I'm sorry. And so then in addition to doing the catheterization approach, you can also do a transapical approach where they go directly through the chest wall, through the left ventricle, and directly right into the aorta and that original AVR, or the valve. So some of your primary nursing diagnoses is obviously going to be decreased cardiac output, risk for infection, fluid volume excess, anxiety, maybe pain. So our overarching goals, I think, for all of these structural heart disorders, obviously, is physical and psychological recovery, return of baseline cardiac function, improved activity and tolerance, And then obviously a lot of knowledge, health promotion, so understanding the disease process and health maintenance measures. Diagnosing and treating streptococcal infections and providing prophylactic antibiotics for patients with a history of RF, rheumatic fever, are critical to prevent acquired rheumatic valve disease. The patient at risk for endocarditis and any patient with certain heart conditions may also receive prophylactic antibiotics. The patient must adhere to ordered therapies. The person with a history of rheumatic fever, endocarditis, and congenital heart disease should know the symptoms of valvular heart disease so early medical treatment may begin. The patient with progressive valvular heart disease may need outpatient care or hospitalization for management of heart failure, endocarditis, embolic disease, or dysrhythmias. Heart failure is the most common reason for ongoing medical care in patients with structural heart disorders. Our role as nurses is to implement therapeutic interventions and evaluate their effects. We should design activities considering the patient's limitations. An appropriate exercise plan can increase cardiac tolerance, but activities that cause fatigue and dyspnea should be limited. Strenuous physical exercise should be avoided because damaged valves may not handle the increased cardiac output demand. Develop your patient's plan of care to emphasize conserving energy, setting priorities, and taking planned rest periods. Consider referral to a vocational counselor if the patient has a physically or emotional demanding job. Tobacco use should be encouraged, and we should educate patients on ways to cease smoking or any tobacco use. We should perform ongoing cardiac assessments to monitor the effectiveness of their drugs and of their treatments. The patient on anticoagulant therapy after surgery for valve replacement must have their INR checked regularly to determine proper dosage and adequacy of therapy. An INR of a mechanical valve should be somewhere between 2.5 to 3.5. That's considered therapeutic. I know in the past, if somebody has a DVT or PE, they may typically want them to stay between 2 and 3. But with mechanical valves, it's a little higher. So we need to teach the actions and side effects of drugs to achieve compliance. The patient must understand the importance of prophylactic antibiotic therapy to prevent IE. If valve disease was caused by rheumatic fever, ongoing prophylaxis to prevent recurrence is necessary. Teach the patient when to seek medical care. Any manifestations of infection, heart failure, signs of bleeding, and any planned invasive or dental procedures require the patient to notify the healthcare provider. When valvular heart disease can no longer be managed medically, surgery is necessary. The patient must know that valve surgery is not a cure and that regular follow-up with a healthcare provider is needed. And finally, we need to encourage our patients to obtain and wear a medic alert device.